Physiology, Section 5, Peripheral Circulation. Chapter 1, General Aspects of the Cardiovascular System. Okay, here is a basic overview of the cardiovascular system. As you know, we have two pumps, a left ventricle and a right ventricle. And we have two circuits, a pulmonary circuit and a systemic circuit. Since these are in series, flow must be the same. So output from the left ventricle, cardiac output, goes into the aorta, goes to our systemic circulation. Output from the right heart, right ventricle, goes into the pulmonary circuit, and that's our pulmonary circulation. The two cardiac outputs are the same. Since they are in series, if one looks at it over time, these are equal to one another. In other words, the output is the same for the left heart and the right heart. Now, there can be some variations at time on a beat-to-beat basis, but overall, if you look at it over a minute or 5 minutes, this output must be the same because they are in series. All right, functional term for us, and this is arterial blood. Arterial blood means high oxygen, low carbon dioxide. If we think about our fundamental function of the cardiovascular system, it pumps blood to the systemic capillaries to deliver nutrients to the tissues. One of those important nutrients is oxygen. Is my patient getting oxygen? Very, very important question. So notice, pulmonary veins and systemic arteries have what we call arterial blood. Functional term. Now, systemic veins and pulmonary arteries have venous blood. Venous blood is low in oxygen and carbon dioxide. Another important aspect of cardiovascular function is to remove waste products from the tissues. This is venous blood. One of those important waste products is carbon dioxide. So the cardiovascular system delivers the groceries and takes out the trash. And it picks up groceries in the pulmonary circulation. That's where we pick up the grocery oxygen. And that's where we dump off the trash, CO2. So again, arterial and venous blood are functional terms. And they're different in the pulmonary circulation because pulmonary veins have arterial blood, pulmonary arteries have venous blood. One of the big differences, remember the flows are the same to the systemic and pulmonary circulation, but what's really different is pressures. Notice right ventricular pressure, peak systolic, is much less on the right side than it is on the left. Pulmonary artery pressure is much lower than aortic pressure. Notice that those capillary pressure in the pulmonary circulation is low. That was a very important construct as we discussed in section 1, because this low pulmonary capillary pressure means we have less of a force promoting filtration. We don't want a lot of filtration into the pulmonary interstitium. That causes pulmonary edema. Pulmonary edema is not a good thing to have. Notice that the pressure gradient, very last line, the pressure gradient is very small on the pulmonary side and it's high on the systemic side. As we're going to talk about, that tells us that the resistance is markedly different. All right, systemic circulation has a much higher resistance and much lower compliance than the pulmonary circuit. We'll talk more about the pulmonary circuit much later, but one of the big aspects of it is the pulmonary circulation has a lot more compliance than the systemic circulation, and it has a lot lower resistance. The lower pressures and lower resistance that the right heart has to work against means it's much less work for the right ventricle than the left. And we already kind of know that because left ventricular wall is much thicker than right ventricular wall. And that's because of the markedly higher work the left ventricle does. And as we indicated on the previous slide, that low capillary pressure helps protect us against pulmonary edema. Okay, from a basic structure-function relationship, we go back to our fundamental function, which is the cardiovascular system delivers the groceries. Where does that occur? In the capillaries. So our arterial blood hits the capillaries. That's where we'll pull off the oxygen to deliver that nutrient to the tissue. And here's where we'll pick up CO2. So that the blood draining it on the systemic vessels, the blood draining it is low in oxygen, high in carbon dioxide, so venous blood. We get the exact opposite when we get to the pulmonary circulation. So notice the big branching and also the idea that we exchange these groceries at the level of the capillary. All right, here is the big key slide, very important slide. This is hemodynamics. All right, hemodynamics, and here's the relationship. Pressure, flow, resistance. It's one of the things that, I recommend that you use for relaxation techniques. Take a deep breath in, then you let it out, and instead of saying, Om, this relaxation, Om, we're going to say something different. We're going to take a deep breath in, and we're going to say pressure, flow, resistance. Pressure, flow, resistance. Such a key aspect for cardiovascular function. Boil it down to that simple construct. Pressure, flow, resistance. In the green box, you see the relationship. Flow is equal to the change in pressure, P1 minus P2, that's the change in pressure, divided by the resistance. Now, P1 we can also call the upstream pressure, or pressure head. This is where we're going to have a higher pressure. It always goes from high pressure to low pressure when we're talking about blood flow. So it'll also occur with respect to airflow. P2 is the downstream pressure. Another term for P2 would be downstream pressure. And again, this is all divided by the resistance. So pressure, flow, resistance. Very, very key fundamental for cardiovascular. All right, here's our pressure, flow, resistance again. All right, we can utilize this. It doesn't matter if it's a single blood vessel or if it's an organ or an entire circuit. Doesn't matter. It's all pressure, flow, resistance. Pressure, flow, resistance. All right, so in other words, for example, if we're looking at flow to the kidney, we would take mean arterial pressure minus renal venous pressure. That's our delta P. So upstream minus downstream. Upstream is mean arterial pressure. Downstream is venous. And we divide that by the resistance, and that will give us the flow. All right, so here's the basic fundamentals. Pressure, flow, resistance. And then upstream pressure and downstream pressure. Upstream is P1, downstream is P2. All right, what are our players for resistance? Our players for resistance are vessel radius, blood viscosity, and vessel length. And resistance is proportional to the viscosity times the length over the radius to the fourth power. Now, we can just look at that basic relationship. Viscosity times length over radius to the fourth power. So what is the key player here? It is radius, because it's radius to the fourth power. And radius can change and change very rapidly. So let's talk a little bit about radius of a blood vessel and how it impacts hemodynamics. If we go back to our basic picture, here's a blood vessel. We have an upstream pressure, P1, and a downstream pressure, P2. And we have blood flowing through this blood vessel. All right, radius is a key player. Now, here's what we're going to lock onto. If I vasoconstrict, if you get vasoconstriction, it means radius goes down, so resistance goes up. So what's going to happen in response to this? Blood flow will go down, upstream pressure will go up, and downstream pressure will go down. That's the key. This is what we lock onto. Own this. This is the fundamentals of hemodynamics. If I vasoconstrict, decreasing radius, upstream pressure goes up, downstream pressure goes down, blood flow goes down. Just lock on that, own it. We're going to work with this. If you've got this nice and tight, we'll show you how you can just work with this very fundamental element to solve some very complex questions. Now, let's rewrite that equation. Notice what it shows. The change in pressure is equal to the flow times the resistance. And that's the reason I use that sequence when I'm doing my relaxation. Deep breath in, pressure, flow, resistance. Yeah, nice and relaxing. Pressure, flow, resistance. And I always say it in that sequence because if you notice, if I rearrange that equation that's in the green box, it shows pressure, flow, resistance. So I always know how to set up the equation, and then you can just move it around algebraically as needed. But notice this key element. Notice this key element. The change in pressure is proportional to the resistance. When this blood vessel vasoconstricted, upstream pressure went up and downstream pressure went down. That means the change in pressure, or the pressure drop, or the pressure difference between P1 and P2 got bigger. So the bigger the resistance, the bigger the pressure drop. Or in other words, the bigger the change in pressure. So when we see a big pressure drop, then we know we have a big resistance. And that's key. We don't even have to do a calculation. You see a big pressure drop, you know you have a big resistance. Big key. Okay, let's just reverse this scenario. Let's vasodilate and decrease resistance. All we're going to do is flip the arrows from the previous. If I vasodilate, blood flow will go up, upstream pressure will go down, downstream pressure will go up. So all we did was reverse what we said before. So vasodilation tends to increase blood flow, decrease upstream pressure, and increase downstream pressure. Just the opposite of when we vasoconstricted. Again, these are the keys. Know this basic construct of what happens with vasoconstriction and vasodilation. Also notice when we vasodilated, upstream pressure went down and downstream pressure went up. So the pressure drop, the change in pressure, became less as the resistance got less. So again, the pressure drop is proportional to the resistance. Now, remember, P1 is not going to get less, not going to become less than P2. P1 will still be higher. The point is that pressure difference, P1 minus P2, gets less when I vasodilate. Because obviously, if P1 became less than P2, then the flow would reverse, which is not really something we're going to see physiologically. So, pressure, flow, resistance. Lock on it, own these basic constructs. What happens to flow, upstream, downstream pressure when I vasoconstrict and when I vasodilate? If you have to go back and review these slides, then please do so. Get this down nice and tight. All right, here are the pressures in the systemic circulation. We start in the aorta, and of course the highest pressure is systole. When the heart's contracting, the lowest pressure is diastole. And the mean pressure is not quite represented accurately on this slide. It should be about 93 in the aorta. But the point is, notice that there's a pressure drop across the circuit. So here we're looking at the systemic pressures across the entire circuit. Now, one of the things we can notice, across the aorta and large arteries, there's a small pressure drop. Across the entire venous side, we see a very small pressure drop. So there's minimal pressure drop across the large arteries. There's minimal pressure drop across the venous side. What does that tell you about resistance? Hopefully you said, well, if there's a small pressure drop, then there is a small resistance. So the large vessels, the large arteries, don't afford a big resistance. The venous side doesn't really afford a big resistance. But notice, look at that huge pressure drop across arterioles. We have a tremendous pressure drop across arterioles. That tells us immediately that's where the resistance is for the systemic circulation. We have a very high resistance, thus we have a very high pressure drop. So if I look at the entire systemic circulation, the main site, far and away, the main site of resistance exists in arterioles. Let's not forget, arterioles can vasoconstrict and vasodilate. And when I vasodilate, upstream pressure goes, do we remember? Upstream pressure goes down. If I vasoconstrict, then upstream pressure goes up. Okay? Very important element. So when I look at the systemic circulation, I can pretty much ignore the resistance everywhere in the normal circulation and say it's in one place, arterioles. Since this is the main site of resistance, this is total peripheral resistance, and as we indicated in a previous section, this is afterload to the heart. Oh, hopefully we remember that when we were thinking about ventricular function. This is afterload to the heart. All right, changing the radius is clearly the biggest player, but another player that we do need to appreciate from a medical perspective, from a physiologic perspective, is the idea of viscosity. All right, viscosity is what? It's that property that measures fluid's internal resistance to flow. Easiest way is to just think about a glass of water and a glass of honey. If I take a glass of water and a glass of honey and I turn them upside down, which one empties first? Yes, the water, much, much faster. And that's because water doesn't have a lot of viscosity. The honey does. It is a viscous fluid. And so when you turn it upside down, it will start to pour out. It will start to flow, but it takes time because of that interaction of the molecules in the honey. So that's basically what viscosity is. So look at the graph on the right. The greater viscosity, the greater the resistance. And as you can see, the main player for viscosity is hematocrit. The greater the viscosity, the greater the resistance. Now I've drawn in on the graph for you the relative viscosity of water. Let's just say viscosity of water is 1. Now, do you remember that blood with 0 hematocrit is plasma? Yeah, exactly. So there's plasma on the graph. Even plasma is thicker than water. See, blood is thicker than water. It's true. It's true. Even plasma is, and that's because of the interaction of the proteins. What the graph shows is that as hematocrit goes up, notice that viscosity goes up, and goes up considerably even at a normal hematocrit. So hematocrit is our major player in blood viscosity. And remember, resistance is directly related to the viscosity. So, big player, prime determinant of blood viscosity is the hematocrit. All right, let's bridge to pathology. Do you remember your 2 conditions related to high and low hematocrit? Yeah, excellent. Anemia is low hematocrit. Therefore, if you look at that purple line, as the hematocrit goes down, viscosity goes down. Woohoo! That's a good thing, right? Less viscosity, less resistance. Yeah, that sounds great. Well, hemodynamically, that's true. But the problem is, don't forget that the hematocrit, that's our measure of red cells, and those red cells are little red trucks carrying oxygen, right? The hemoglobin in the little red cell, our little red truck, is what's carrying oxygen. So the problem in anemia is not the hemodynamics related to viscosity. They actually get better. But the problem is I don't have enough red trucks carrying oxygen. All right, so let's just make more red trucks. Well, that's polycythemia, but notice how that curve starts to rise exponentially. So as that hematocrit goes up and up, yeah, I have more red trucks, but the downside is I have increased viscosity. That means increased resistance to blood flow. And as I'm sure you know, a lot of elite endurance athletes take EPO. Well, that's blood doping, right? That increases hematocrit. Probably works because a lot of them do it. The idea is I got more red trucks. The trade-off is viscosity of blood has gone up. Now, these elite endurance athletes, they can deal with a higher viscosity and a higher resistance. Why is that? Because the work of the heart. This increased resistance means increased work of the heart. An elite endurance athlete can really pump out some blood. They have a very, very strong heart. But imagine a 55-year-old who's had 2 myocardial infarctions. The strength of their heart is nothing compared to an elite endurance athlete. So if they get polycythemic with that increase in resistance, their heart might not be able to deal with that very high viscosity. So our other player for step 1 is indeed blood viscosity. Directly related, viscosity and resistance. Technically speaking, resistance is directly related to the length. The greater the length, the greater the resistance. So of course, if the length doubles, then resistance doubles. If length goes down by half, then resistance decreases by half. Okay? But, when's the last time the length of your blood vessel changed? Probably not very recently. So I wouldn't worry too much about length being a player on USMLE Step 1. Okay, the next concept for cardiovascular, and as you're going to see, this chapter is going to have a lot of concepts. If we'll just understand these basic concepts, we can work so easily with a whole variety of things that stem from them. We can just keep pulling from this basic information. We're not trying to memorize, we are understanding. If we got this understanding down well, we can work with it again and again and again. Next concept is velocity. Velocity is the rate at which blood travels through a blood vessel. Do not confuse this with flow. Flow is a volume per unit time. Velocity is how fast it is traveling. All right? They are related because mean linear velocity is proportional to the flow. However, it's inversely related to the cross-sectional area. So mean linear velocity equal flow over cross-sectional area. So velocity and flow are not the same. They are directly related, but they're not the same, because if cross-sectional area changes, then it may affect the flow, but it's most certainly going to affect the velocity. So a big increase in cross-sectional area means a low velocity, and vice versa. One of the applications of this important functional application is we have a huge cross-sectional area in capillaries. Because we have a very high cross-sectional area, velocity is low. But cross-sectional area in the aorta is very low. So we have a lot of flow, but a low cross-sectional area, therefore a very high velocity. So velocity is high in the aorta and low in the capillaries. And we like it low in the capillaries because remember, that's where we get grocery exchange. And the low velocity facilitates grocery exchange. Since the aorta has a high velocity and it also has a large diameter, one of the things that we have to be concerned about is the idea of turbulent flow. All right, let's talk about the idea of turbulent flow. The picture on the lower right shows what we call laminar flow. We're going to have 2 types of flow, or at least the potential for them, in the cardiovascular system. We're going to have laminar and turbulent. So the picture in the lower right shows laminar flow. And, here's the way to think about it. Just imagine the blood flowing and it occurs in layers. All right? There's infinite number of layers in there. The flow occurring dead center will actually have the highest velocity, and this is where we'll have the highest flow, dead center. and everything to the sides of that, above and below, will be just a little bit slower, a little bit slower, a little bit slower, a little bit slower. And that's the profile you're seeing. So just think of it as layers, Laminar flow is the normal flow pattern in the cardiovascular system. That's what's typical. Now let's talk about turbulent flow. Notice the picture down in the lower right. This is turbulent flow. We no longer have those layers, those sheets of flow occurring. Notice the chaotic pattern of turbulent flow. All right, what determines if flow is laminar or turbulent? Well, it's something called Reynolds number. And if Reynolds number becomes greater than 2000, then there's turbulence. If it's less than 2000, then we have laminar. The 2000 is not what's crucial. What's crucial is, the players. Big diameter, high velocity, those are going to be scenarios where we're more likely to have turbulent flow. If we have a very viscous blood, like polycythemia, then it's going to be less likely to have turbulence. I really wouldn't worry about density of blood changing. It's not something that typically occurs. So again, big diameter, high velocity, more likely to have turbulence. High viscosity, less likely to have turbulence. Or stated another way, low viscosity, like anemia, is going to enhance the likelihood of turbulence. All right, why do we care about turbulent flow? Two big things about turbulence. Because turbulence you can hear. And so this will be, if you have it in a peripheral blood vessel, something called a bruit. So a bruit means an abnormal sound in a peripheral blood vessel. Since blood is normally flowing in a laminar pattern, you can't hear it. So when you put a stethoscope on a peripheral blood vessel, you shouldn't be able to hear anything because it's laminar flow. If you do hear something, then you know it's turbulent. All right? It's turbulent. And the big thing to think there, very first thing, is a stenosis. High velocity in a stenosis. Second, there's a lot more resistance when flow changes from laminar to turbulent. And if we just look at the picture of it, right? We don't have that layers, we don't have those sheets. That was a nice, pretty picture for laminar. This is a very chaotic pattern of flow. So hopefully it makes sense to you that, turbulent flow will have a greater resistance than laminar flow. So those are the two big keys. If you get turbulence, you can hear it. That's a bruit. And that means resistance is elevated. All right, we can alter Reynolds number a little bit. Atherosclerosis will reduce Reynolds number at which turbulence begins. So atherosclerosis, we're going to have more likely to have turbulent flow. And thrombi are more likely to develop with turbulent flow than in laminar flow, because this very chaotic pattern can initiate that clotting cascade. All right, so to recap and review again, development of turbulent flow. What's going to promote the likelihood of turbulent flow? Increasing the tube diameter, increasing velocity, or decreasing viscosity. Those are going to be the big players. So big tube diameter, high velocity, and low viscosity, like anemia. If we think about anemia and the aorta, remember we said the aorta is a big vessel and it has a high velocity because it has a low cross-sectional area. So if someone becomes anemic and viscosity goes down, then they're much more likely to develop turbulence. And one of the places where we may develop that turbulence is, of course, the aorta. Other things that will do it are branching of blood vessels. That's going to create a scenario where we're more likely to generate turbulence. And also, as we indicated before, a stenosis due to the very high velocity. I mean, think of a clinical vignette on step 1 where they put a stethoscope over the right carotid artery. And as a result, they hear a murmur. So they put a stethoscope, right carotid artery, they hear a murmur, you're thinking stenosis. Now let me ask you this. What's pressure downstream from the stenosis compared to a normal blood vessel? What's pressure downstream from the stenosis compared to a normal blood vessel? Oh, you got it. Very good. Pressure downstream will be less. Pressure downstream will be less. Why? Because turbulence increases resistance. And remember, the pressure drop increases as the resistance goes up. So if resistance is going up, upstream pressure goes up, downstream pressure goes down. So the pressure inside the carotid artery downstream from the stenosis will be less than in a normal individual. That's less of a pressure head driving flow. That's part of the reason that we can have decreased flow to the brain with the carotid stenosis. And again, the vessel in the systemic circulation, all right, systemic circuit closest to the development of turbulence is the aorta, as we mentioned now a couple of times, because it has a big diameter and it has a high velocity. Okay, very quickly, don't forget the idea that series resistors, the total resistance sum. So the total resistance is resistance 1 plus resistance 2 plus resistance 3. If resistors are in parallel, then total resistance is added as reciprocals. So 1 over total resistance is 1 over resistance 1, 1 over resistance 2, etc. Bottom line, here's all we really have to hone in on this step. Total resistance is less in parallel circuits compared to series circuits. And the systemic circulation is set up in parallel. Even though we have a higher resistance systemic compared to pulmonary, just think how high the resistance would be if the systemic circulation was in series rather than in parallel. So here again, we're just recapping that idea. Blood flow to the systemic circulation is parallel branches off the aorta, so total resistance is less than if they were in series. All right, here's a picture of the systemic circuit. We're going to do some deep thinking on this slide. All right, we're going to put in to play some of these basic principles that we've discussed. All right, we're going to apply some very fundamental constructs. First thing I'm going to do is I'm going to put a little symbol in here. I'm going to say this represents a resistor. Now remember, we discussed before, arterioles are the resistors. So bottom line, I'm putting in the picture or the idea that all the various vascular beds, the liver, the gut, the kidneys, etc., all have arterioles. And these arterioles, as we indicated, are resistors. So that's the basic idea of what I'm putting on here. All right, total resistance is the sum of each of these resistors. Yes, it's added as reciprocals because it's in parallel, but total resistance, TPR, total peripheral resistance, you could also call it systemic vascular resistance, SVR. Both terms are acceptable and interchangeable. So total resistance of the systemic circulation, TPR, is related to these arterioles because that's the main site of resistance. And as we also indicated, don't forget, these arterioles, this resistance is afterload for the heart. All right, now, because the main site of resistance is arterioles, this is going to have two very, very important functional consequences. First, arterioles represent the gatekeeper of flow. All right, they are the regulator of flow to the capillary. Because the arterioles are upstream, think about direction of flow, arterioles are upstream from the capillary. They're the main resistor, so they're going to regulate flow to the capillary. And that becomes important because that's where we get grocery exchange. Second, they're going to regulate upstream pressure. Well, what's upstream from the arterioles? Pressure in the aorta. This is mean arterial pressure. So big dual functional role of arterioles being the resistors. They're the gatekeeper of flow, and they regulate upstream pressure. Now, a beautiful example of a resistor is a faucet. Just think of a faucet in your house or apartment or wherever you live, right? You turn the faucet, you decrease the resistance, it allows some water to flow. The more you turn it, that means the less and less the resistance, the greater and greater the flow, right? Okay, it's a variable resistor. You can turn it to where the faucet is turned off. That means effectively infinite resistance. Now, we don't really have that in the cardiovascular system, but hopefully you get the point. So think of all of these little arterioles that in each vascular bed that it represents a faucet. A faucet. Okay? So the heart or the brain, for example, or the kidney, for example, think of them, this is grocery delivery. One of the functional consequences of this faucet, the resistor is the faucet. One of the functional consequences of this faucet is it's influencing grocery delivery. So the tissue wants to regulate the faucet. It wants to open it up and make sure that it's getting grocery delivery. But you can't have all the faucets wide open simultaneously, because that's where our other player comes in. I have to have a certain level of resistance at these various resistors in order to maintain an adequate mean arterial pressure. I can't fully open all the faucets. Imagine in your city that you live, if everybody simultaneously opened all their faucets, well, you wouldn't get any water flow because the pressure head would plummet. Same in the body. If you try to open all these faucets wide open, that means resistance falls too low, and thus mean arterial pressure falls too low. And now I don't have a pressure head to drive flow. So I can't have them open simultaneously. Dual role. Gatekeeper of flow. So they regulate flow to the capillary. That's grocery exchange. But I must have some level of resistance in order to maintain mean arterial pressure. Pressure, flow, resistance. Pressure, flow, resistance. Notice the relationship I just showed. Mean arterial pressure is cardiac output times TPR. We're just putting pressure, flow, and resistance together by just using whole body hemodynamics. All right, can you think of any beautiful examples in which those faucets tend to be too open and resistance is too low? Do we have any pathologic states where that occurs? Yeah, if you said septic shock, excellent, excellent. That's exactly the fundamental threat to the cardiovascular system is the faucets being open. That's what happens in septic shock, this peripheral vasodilation. Same is true in anaphylactic shock, can also occur in neurogenic shock. I don't have adequate resistance to maintain the pressure head. Can't have all these faucets open simultaneously. And that is such a key, important construct. So, pressure, flow, resistance. Arterioles are the resistors. Two functional consequences. This regulates grocery delivery and it impacts upstream pressure. All right, so let's continue on with applying this idea. Let's think about what's going to vasoconstrict arterioles. By vasoconstricting arterioles, we're going to tend to reduce flow to the capillary, but increase upstream pressure. One of your first thoughts should be norepinephrine. Norepinephrine release from sympathetic postganglionic neurons binds to alpha-1 receptors. Do you remember the signal transduction for alpha-1? Very good. I hope you said GQ. All right. GQ-IP3 releases calcium. GQ, the best dressed of all the G proteins. So norepinephrine binds alpha-1, activate GQ, vasoconstriction, that makes upstream pressure go up, reduces flow to the capillary. All right, some other players that'll cause vasoconstriction are hormones. Epinephrine, remember it released from the adrenal medulla, can also vasoconstrict via alpha-1. Angiotensin II is a vasoconstrictor. We express vascular AT1 receptors. Also use GQ. Next is arginine vasopressin, which is also known as antidiuretic hormone. So arginine vasopressin AVP or antidiuretic hormone ADH can bind to vascular V1 receptors. Again, GQ, you're starting to see a theme here. Alpha-1, AT1, V1, the 1, 1, 1, GQ, 1, GQ, 1, GQ. All right, let's put a little bridge to pharmacology and think about vasoconstriction and blood pressure going up. We have norepinephrine binding to alpha receptors. That is a major player in regulating it, so think of your class of drugs, right? We have drugs like alpha-1 agonists that are going to make blood pressure go up because they vasoconstrict. Can you think of any? If you said phenylephrine, yeah, that's the classic. That's the classic. We could also give drugs that cause the release of norepinephrine. Do we remember drugs that will cause release of norepinephrine? If you said ephedrine, excellent. If you said amphetamines, excellent. And the other one was, maybe you said tyramine, excellent, excellent. Yeah. We could also block reuptake. Remember, we have to have a way to shut off neurotransmission. For noradrenergic neurons, the main mechanism is reuptake. The main mechanism stopping neurotransmitter activity here is reuptake of norepinephrine. So if I inhibit the reuptake of norepinephrine, norepinephrine lasts longer and you vasoconstrict. Can you remember drugs that inhibit reuptake? Yeah, very good. Cocaine, excellent. Cocaine and the tricyclic antidepressants. So again, we just bring in the pharm. We just immediately put in the class of drugs because we understand the physiology. All right, let's go the other way. Let's vasodilate arterioles. If I vasodilate arterioles, I'm going to tend to increase flow to the various capillary beds, but I'm going to drop mean arterial pressure. Things that are going to cause vasodilation, hopefully your first thought was the physiology of it. That would be decreased sympathetic activity. By reducing norepinephrine output, I decrease alpha-1 vasoconstriction. Next, don't forget, epinephrine, it will bind alpha-1, but it can also bind beta-2. Norepinephrine not a good agonist for beta-2, but epinephrine is a good agonist for vascular beta-2. And beta-2 work through GS cyclic AMP, which relaxes smooth muscle. That is a huge point for step 1, all right? Epinephrine will work on beta-2 receptors to cause vasodilation. And what's one of the big vascular beds where that occurs? Yes, very good, skeletal muscle, skeletal muscle. But your first thought should be norepinephrine reduction in its release, but also we could inject epinephrine to activate vascular beta-2. Other vasodilatory mechanisms, just say no. No! No! Yeah, no is nitric oxide. Release from vascular endothelium activates soluble guanylyl cyclase to increase smooth muscle cyclic GMP. Nitric oxide is a very, very potent vasodilator and very important one to remember for step 1. 1992 Science Magazine Molecule of the Year. Compounds released from the tissue can also do it, related to metabolism, like adenosine, which we get from the breakdown of ATP, carbon dioxide, potassium, hydrogen ion. All of these are vasodilatory mechanisms. So when a tissue increases its metabolism, we will tend to increase its flow. We will see that theme in Chapter 2 as well. Now let's bridge a little bit to pharmacology. Those are our endogenous mechanisms. So what are some classes of drugs that can cause vasodilation? Well, we can block alpha receptors. like phenoxybenzamine. We have selective alpha-1 blockers. Can you think of any of those? Yeah, like prazosin. Very good. Terazosin. Very good. We also have drugs that can work by liberating NO or activating NO in some way, like nitroprusside, nitroglycerin, hydralazine. Does that ring a bell? Calcium channel blockers. Did you immediately say dipene? Dipene? Yeah. Nicardipine, nifedipine, the dipenes tend to work on peripheral vasculature to cause vasodilation. And last but not least, drugs that work through potassium. Now let's think about it. If I'm relaxing that smooth muscle, am I hyperpolarizing it or depolarizing the smooth muscle? All right, hopefully you said hyperpolarizing. Now, if it's hyperpolarizing and I'm working through potassium, did I increase potassium conductance or decrease potassium conductance? Oh, very good. We increase potassium conductance. Very good. By increasing potassium conductance, we hyperpolarize and it relaxes. Do you know the drugs that work through potassium? If you said minoxidil and diazoxide, you did well. Excellent job. Excellent job. So again, we understand this physiology allows us to incorporate the pharmacology. Okay, the next concept that we need to think about for cardiovascular physiology and USMLE Step 1 is the idea of wall tension. Wall tension is defined by the law of Laplace. And the law of Laplace states that wall tension is directly proportional to the pressure times the radius. So wall tension equal pressure times radius. Now, the aorta is the artery with the greatest wall tension because it has the highest pressure and the biggest radius. Now, what is wall tension? Wall tension means that circumferential force, that force around a blood vessel, or it could be a sphere like the heart, it's that force tending to rip that blood vessel open. Think of a balloon filling up with water. It gets more and more and more water in it. Then the pressure's going up and the radius is going up, so it's stretching the walls of that balloon. That's wall tension. You could also call it wall stress. But it is that force tending to rip that balloon. Same thing for the cardiovascular system. So if you put too much water in there, there becomes too much pressure, too much radius. Therefore, the wall tension's too great and the balloon rips. Similar scenario for blood vessels. One of the big applications we're looking for on wall tension is an aneurysm. So a pathologic integration here. Here's a picture of an arterial aneurysm. Now the pressure inside the vessel at points A, B, and C all along that vessel, remember there's very little resistance here, so the pressures are the same. But the aneurysm, which is a ballooning out of a blood vessel, this aneurysm will have elevated wall tension because even though the pressure is the same, the radius is much greater. So therefore, the more and more this blood vessel distends, the greater and greater the wall tension. Very similar to what we just described on the previous slide, the idea of a balloon filling up with more and more water. So aneurysms are dangerous because the bigger they get, the more likely they are to rupture. And we can have cerebral aneurysms, but also more common is an abdominal aortic aneurysm. In addition to an abdominal aortic aneurysm, we can also have what's called a dissecting aneurysm. So here's a clinical example of an aortic dissecting aneurysm. Systemic arterial disease, we get a very high velocity in the aorta because of the low cross-sectional area. Remember, as cross-sectional area falls, velocity goes up. Well, that velocity can damage the endothelial lining, allowing that blood to penetrate into the intima, past the intima of a blood vessel. This is when we call it a dissecting aortic aneurysm, because it's effectively dissecting the layers of that blood vessel. This will weaken the aortic wall and, of course, is a life-threatening condition, because if that aorta ruptures, one can hemorrhage out very, very quickly. Now, let's recall a big clinical sign. What's a big clinical sign of a dissecting aortic aneurysm? If you said pain, a sharp pain, particularly in the back, a ripping pain in the back, yeah, that's suggestive of an aortic dissecting aneurysm. Again, aneurysms can be life-threatening, but a dissecting one is certainly life-threatening. Second big example to take into consideration for step 1 and wall tension is a dilated heart. In congestive heart failure, we typically have a dilated ventricle. So as that ventricle dilates more and more, that's greater and greater radius. So this increases the chamber size. It's dilating. This is a greater tension on the failing ventricle, which also will reduce its performance. The ventricular wall, the muscle is not strong enough to deal with or overcome this wall tension, and thus reduces output. So aneurysms, abdominal, aortic aneurysm, a AAA, dissecting aortic aneurysm, and also a dilated heart. All of these come into play when we're thinking about the idea of the law of Laplace, which defines wall tension. And again, wall tension is simply pressure times radius. All right, next big concept for cardiovascular is the idea of compliance. Compliance, if we just think about what the word means, just think about it. You know, if someone said to you, well, what is compliant? What's a compliant person? A compliant person would be someone who gets along easily, kind of goes with the flow, easily moved or malleable. That's a compliant person. Well, compliance physiologically is very, very similar. Compliance is how easily a vessel is stretched. Technically, it's the pressure-volume relationship when there's no flow. So compliance is the change in volume over the change in pressure. That's what it is mathematically. Compliance, very important concept, just like pressure, flow, resistance. Yeah, pressure, flow, resistance. Well, this is compliance, volume, pressure. Notice that we have pressure in both of them. But if we're thinking about flow, then it becomes pressure, flow, resistance. If we're thinking about pressure when there isn't flow per se, then we're thinking about compliance. And again, compliance is the change in volume over the change in pressure. The more compliant, the more easily it stretches. All right, what's the inverse of compliance? Elasticity. So if a vessel has high elasticity, this is a big tendency to rebound from stretch, it has low compliance. Elasticity means that property which resists change. So something that's highly elastic has low compliance. Something that has low elasticity is therefore highly compliant. They are inversely related. Compliance is very important for the cardiovascular system. It's huge in the respiratory, so please get down the concept. Now, application. Big compliance for the cardiovascular system are veins. Systemic veins are 20 times more compliant than systemic arteries. So, as a result, they distend easily, so veins hold the blood, about 70% of the blood volumes in the veins. And the easy way to think about it is, at any given time, most of the blood volume is in the veins. Reason? They're more compliant. Now, if blood is in the veins, this blood that's in the veins is not available for the heart to pump, and therefore it's not contributing to circulating blood volume. This goes back to the idea of Frank Starling once again. If the heart don't get it, the heart don't pump it. So if blood just is sitting in veins and it's not getting back to the heart, then that's going to reduce output. And we'll talk about situation associated with that very soon when we talk about orthostatic stress. Now, when considering whole body, here's a big key. When considering whole body hemodynamics, compliance, veins, all right? The compliance of the systemic circulation is venous compliance. We pretty much ignore, when we're thinking entire circulation, we pretty much ignore arterial compliance. It's veins. So the arterioles are resistors for the whole circulation. Remember, we pretty much ignored venous resistance. Now, when we're thinking whole circulation and compliance, we think about the veins. This is not to say that the arterial system has no compliance. And compliance will come into play, and we will discuss that when we talk about the pressures in systemic arteries. But when we're thinking of the whole body, compliance, veins, they go hand in hand. Compliance and veins. All right, now that we're talking about the idea of veins, we understand veins are very compliant. Now what we want to bring in is an important concept called venous return. Please familiarize yourself with the abbreviations on this basic picture. Here's a basic picture of a cardiovascular system. Of course, LH is left heart, RH is right heart. CVP is central venous pressure or right atrial pressure. Remember, those pressures are basically the same. Mean arterial pressure is that pressure head driving flow to the peripheral circulation. Now, a term we haven't discussed yet, now we're going to go into considerable detail, is PSF. This is mean systemic filling pressure. All right? Mean systemic filling pressure. And it's illustrated because it's a concept. It's not something that you can truly measure in a patient. You could, but it would require you to stop their heart. And so it's not ever done. But let's think of it as a concept. All right, PSF, mean systemic filling pressure, is that pressure in the circulation when there is no flow. All right, so again, it is that pressure in the circulation when there is no flow. That's what mean systemic filling pressure is. Again, we don't measure it, but we can think about the concept of it and what's going to influence it. The reason that's so important is because PSF is a huge player in determining venous return. All right, let's talk about venous return and its regulation. Venous return is the flow of blood back to the heart. So if I break the circulation down, I can talk about output, that's cardiac output, that's what's going into the aorta. Venous return, on the other hand, is the flow, it's a flow, venous return, flow of blood back to the heart. The reason this is so important is because venous return determines preload. I want you to put that in your mind and just sear it in, tattoo it to your brain. Venous return determines preload. And as we've already discussed, and we'll bring back in again, preload is a big player in ventricular function, right? Tip your cap to the ventricle for keeping you alive. That P in cap is preload. This is Frank Starling. All right, now, venous return is a flow. Therefore, it must follow the physics of flow. It is directly proportional to a pressure gradient and inversely related to resistance. Pressure, flow, resistance. Now, right atrial pressure. This is blood flowing into the right atrium. So venous return ends up, its final destination is the right atrium. So hopefully it makes sense to you that right atrial pressure is the downstream pressure for venous return. All right, now here's the big key. What's the upstream pressure? Mean systemic filling pressure. All right, mean systemic filling pressure is the pressure head driving venous return. And again, mean systemic filling pressure is that pressure when there's no flow. So for venous return, pressure flow resistance, we have to have a pressure gradient. And the pressure gradient is PSF minus right atrial pressure. Let's continue on with that idea. Here's our picture of the circulation, and we're just going to recap what we just stated on the previous slide. So venous return is the arrow to the left on the venous side. All right, that's venous return. That's the flow of blood coming back to the heart. Must follow the physics. Flow is change in pressure over resistance. So, as we defined on the previous slide, and hopefully again it makes sense, the downstream pressure, or P2, is right atrial pressure. The upstream pressure, the pressure head, is mean systemic filling pressure. This is the pressure in the circulatory system when there is no flow. So, therefore it follows, venous return is equal to PSF minus right atrial pressure divided by the resistance. So stop, absorb, soak in that construct. It's pressure flow resistance. All right. Now, mean systemic filling pressure is a pressure when there's no flow. So if there's no flow, we're not thinking pressure flow resistance to determine PSF. Instead, we're thinking volume and compliance. All right, segregate those out in your mind. PSF is that pressure when there's no flow. As we discussed earlier with compliance, if we're thinking no flow, and we're thinking about factors that influence pressure when there's no flow, then it's volume and compliance. PSF is directly related to volume and inversely related to compliance. All right, so let's think about volume. Volume where? Well, blood volume. This is total blood volume. Not venous volume, total blood volume. And as we also discussed just a few moments ago, compliance for the whole circulation is where? Yeah, hopefully you said veins. Veins. So therefore it boils down, we break it down. PSF is directly related to blood volume and inversely related to venous compliance. PSF is directly related to blood volume and inversely related to venous compliance. And PSF is the pressure head driving venous return. All right, let's recap. Mean systemic filling pressure is determined by blood volume and venous compliance. So therefore, there's a direct relationship between blood volume and PSF. Now think about it. The greater the blood volume, the higher the PSF. They're directly related. If I reduce blood volume, I'll reduce PSF. Hopefully you're already thinking just a little bit ahead of me. But we will go through it. If PSF goes up, then venous return goes up. If PSF goes down, then venous return goes down. So venous return is going to be directly related to blood volume. Again, we'll go through that. Now, PSF is inversely related to venous compliance because that's the compliance for the systemic circulation. So the more compliant the veins, the lower the PSF. The less compliant the veins, the higher the PSF. All right, let's continue working with this concept. Since PSF is the pressure head driving venous return will be directly related to PSF. So all other factors unchanged. If I increase blood volume, I increase venous return. Because increasing blood volume increases PSF. If I decrease blood volume, I decrease venous return. Because if I decrease blood volume, I decrease PSF. And PSF is the pressure head driving flow. If I decrease venous compliance, and now on this slide it illustrates, how do we do that? Sympathetic stimulation will be the main way. This will be an alpha-mediated vasoconstriction, more specifically venoconstriction, and also engaging the muscle pump. And the muscle pump is contracting and relaxing skeletal muscle. Just think of exercise. If I increase venous compliance, and we can certainly do this as well, that's inhibition of the sympathetics, also giving drugs like nitroglycerin, which can venodilate, and also blocking alpha receptors will decrease venous return. Now, you also have to remember that most of the alpha blockers, their predominant effect is on the arterial side. So it gets a little bit tricky with respect to alpha block. But alpha block could cause some venodilation, or in other words, increase in venous compliance. All right, let's work our way through, once again, just using this picture, the idea of venous return and changing PSF. All right, let's start with increased vascular volume. If volume goes up, then PSF goes up. So PSF going up means increase in venous return. Just follow the up arrows. Volume goes up, PSF goes up. Well, it's the pressure head. So if PSF goes up, then venous return goes up. Decreasing vascular volume has the opposite effect. If vascular volume, remember this is total blood volume, if volume goes down, then PSF goes down. And if PSF goes down, that's the pressure head going down, then venous return goes down. So decreasing vascular volume reduces venous return. All right, now let's just apply, looking at the mathematics of it, a decrease in venous compliance. If venous compliance goes down, and how do I reduce venous compliance? Muscle pump, engaging the muscle pump, more specifically sympathetic venoconstriction. If compliance goes down, then PSF goes up. And once again, if PSF goes up, then that means venous return goes up. So if I squeeze the veins using the sympathetics, where's that blood going to go? To the heart. To the heart. Hopefully that makes good sense to you. Stimulating sympathetics is effectively squeezing these compliant veins, which in turn is driving blood flow back to the heart up. So in other words, increasing venous return. All right, let's go the other way. Increasing venous compliance. Venodilators, as we indicated. Classic example of it, or inhibiting sympathetics. If compliance goes up, then PSF goes down. Well, and if PSF is going down, that means the pressure head's going down. That means venous return is going down. Hopefully this also makes sense to you. If I dilate the veins, they're going to fill up with blood. So earlier we said the idea, we brought forth the concept that if the blood is in the veins, then it's not available to the heart. Well, here's the example. This is a perfect example. If I venodilate, the veins balloon out, they're holding more and more blood. That means it's not getting back to the heart because venous return is going down. So it's just an application of what we discussed earlier. So hopefully we have a good concept, a good construct. All right, we understand the idea of venous return and what's driving venous return with respect to changing PSF. If not, please go back and review, because now we're just going to continue building on to this.